Good morning. It's still morning. It's hard to believe. The morning has been so dense. I can hardly imagine what it's like to sit and hear this for the first time. The good news is, what I've found this morning is that you all are an incredibly discerning audience. So imagine my surprise when I thought I was showing up to a symposium where we were going to talk about the basics of the biology, the basics of molecular analysis, the basics of putting together diagnosis and treatment planning, but you all are the elite of the elite. So it is my privilege to be here with you this morning. I also want to do a couple things before I get into exactly what it's like to live with pancreatic cancer and treatment for a moment. Number one, we're in the presence of scientific luminaries that I want you to appreciate is exceedingly rare. Dr. Go, who was the first person to learn how to diagnose pancreatic cancer back in 1969 using angiography at the Mayo. So he's the reason we're all here today. He actually discovered the way to find pancreatic cancer back when we would find it largely on autopsy. So thank you for being here this morning, Dr. Go. Dr. Tempero, who wrote the NCCN guidelines, she's being modest. So the National Comprehensive Cancer Network is an affiliation of the 41 NCI designated cancer centers. Only the most significantly advanced and successful researchers are invited to chair the guideline committees that establish the standard of care for cancer in America and globally now as well. So I really want to pause and say it's really because of Dr. Tempero that we've thought more about thinking about the thinking and expanding our knowledge of not just pancreatic cancer, but those other pernicious, difficult, hard to find cancers that are still poorly understood. She's a rock star. So thank you. And I'm glad you came back in the room because it would be remiss of me to not recognize my partner in crime, my dyad physician lead here for all of cancer services here at UCLA, Dr. Tim Donahue. Tim treats patients from all over the world, and he's the guy you call when laparoscopic surgery is no longer appropriate and something more broad, potentially invasive and complicated. So thank you, Tim. It's such a privilege to be with you this morning. And then Dr. Muthuswamy, I would be remiss in mentioning, if you have a cyst, if you have an abnormal MRI, and I count myself among you, he's your guy. So I know who I'm calling after we're done today. So thank you for being here. So here's how I'd summarize I should stop and say I'm a lifelong oncology nurse, and this spring I've been at it for 40 years. So I actually, thank you. Remember when leukemia was a death sentence? Remember when GI cancers were something you only found when it spread throughout the entire body? Remember when this thought that you could use the immune system to target and treat cancer cells individually? Remember that when those were novel concepts, 5 years ago? See how far we've come. See how we're poised to go so much farther. I hope you'll leave today feeling really encouraged at what we've accomplished and where we're about to go. So how I'd summarize the morning, because I'm going to change gears pretty dramatically here, is in the beginning, there's a lot we know about pancreatic cancer, and there's a lot we don't know. In particular, the mutation affiliated with KRAS offers tremendous potential to learn more both the molecular level and the biologic level about the behavior of these cells. My favorite term from the morning is wild KRAS, the kind we can't categorize. I think that's so descriptive. That's scientific creativity at its finest. The other things to know is that we're still trying and failing and trying and succeeding. And the more we know, the more we find out we don't know. So I hope you'll be inspired this morning with what we know, recognizing the challenges are before us, or learning to live with the uncertainty of what we don't know and how to manage it. So I'm going to be one of 3 speakers who take it down several notches. I'm here to talk to you about living well with pancreatic cancer and treatment, followed by Shelby this afternoon, who's going to talk to you about managing diet and nutrition through the disease, and then finally with some mindfulness toward the end of the program before the panel. So put aside your scientific exploration hat and join me, and many of you will have ideas, suggestions, and thoughts on managing well with pancreatic cancer. Did it work? It did. Okay, so in the beginning, there is knowing you have pancreatic cancer. You have a diagnosis, and for many of you, that's a journey in and of itself. Perhaps you've been through years of surveillance. You've had germline testing. Everybody caught that this morning. There's inherited types of risks for cancers. Those are the germlines. The somatic are the ones that aren't inherited, otherwise known as misfortune or bad luck. Still all need surveillance, all need examination, radiologic or otherwise, and then finally you get to a diagnosis. So then, of course, what stage are you? What type are you? What mutation expression do you have? And the selection of treatment. This is where many people consider surgery, but if it's advanced, maybe not so much. Maybe it's systemic therapy, especially if we have mutation-targeted therapies available, as well as spot radiation. I didn't even put radiation on my slide because it's still available to a relatively small cohort of patients. So assembling your care team, you'll notice that I choose my words really carefully there, because now that you've entered the stage where you know or suspect or believe you have pancreatic cancer, your healthcare providers aren't the most important people in your lives. It's the people who take care of you at home, in the place you work, in the place you worship, in the place you celebrate, for instance, sports. Family, friends, and caregivers will loom large and absolutely dominant and be willing to serve. My major message for you today is rely on your care team, let people in, invite them to join you in this journey. So let's pivot back to the healthcare team. Once again, when I wrote these slides, I didn't quite imagine that you all could probably write this for me because you've already been through it, or you're going through it now and have these team members working with you. I cannot underemphasize the importance of your care coordinators and schedulers. So some of you have navigators, some of you have clinical nurses working with your oncologists and your surgeons. Some of you have patient service representatives. They come in all different types. But the person who manages your clinical schedule and all the features, radiologic, laboratory, surgical, follow-up, and all the multidisciplinary team members I'm going to emphasize in a few moments, this person will help you organize it in a way that matches what you can accomplish. So make friends with your scheduler. Your nutritionist, I don't want to steal Shelby's thunder, but pancreatic cancer will change the way you eat, it will change the way you digest, and it will change the way you eliminate. And all of that means it changes the way you exist with your family and the world. So, and sometimes we give you diabetes. So nutritionist will be key to your success. I encourage you to once again have a nutritionist, find one if you don't have one, and partner with them regularly to adjust how you eat and relate to the people around you. So physical therapy, this is where I really want to emphasize, and I can tell most of you in the room and possibly online are type A people. You're used to being active, you're used to being involved, and you're accustomed to setting your own pace. You're about to not have that privilege any longer because both the condition and the treatment are going to change your ability to autonomously decide how much energy you have to expend. And a physical therapist, a physiotherapy professional, can help you do that self-assessment and make adjustments to your activity. Everybody wants to keep exercising because all the literature says the more you exercise, the better your immune system will respond to treatment, the more effectively your cancer will be treated. That literature isn't wrong, it's not sensitive to how sick you are at the time. You have to take responsibility for that. Okay, so we're just going to pivot to the basics. You have to prioritize nutrition and successful ingestion for successful recovery. So that means immediately following surgery, you're going to have trouble with fat absorption and peristalsis. Things aren't going to move through as swiftly as they were before surgery. So small, frequent meals, working with your nutritionist to make sure they're high protein, moderate, healthy fats. This is where the eggs, the legumes, the protein shakes come in. Sometimes there's pancreatic enzyme replacement therapy. I can't underemphasize the need to stay hydrated. For some days, the only thing you might be able to take in are liquids. I'm personally not a fan of energy drinks, but I think nutritious shakes and other electrolyte replacement therapies can be helpful. And you're going to really want to watch for weight loss. So I know in America it's all about the GLP-1s and we're really into weight loss. This isn't the desirable kind. We really want you to stabilize your weight, sustain your weight, because those are the reserves you'll call on as you continue your recovery. You're seeing in the wellness media all the time now. You have to have leg day, because leg day means your muscles are strong and you're not going to get dementia. I'm sure this is true. As it relates to thinking about pancreatic cancer and recovery, sustaining your hydration and your nutrition will help you stay healthy enough to continue to recover. Loss of appetite and early fullness are customary. So if you've had GLP-1s, this is going to be eminently familiar to you, but it might be new and different in pancreatic cancer because it's likely to be more profound. Watch your blood sugar. If you have pancreatitis or you have diabetes, you already know how to do this. But for those of you who will be new to this realm, because we took out most of your pancreas or it's not functioning normally, we'll need to introduce you to managing the technology these days to manage and monitor your blood sugar and change your diet, ideally avoiding simple sugars as much as possible. So, what did I say? It's really important to figure out what to eat and how to eat well. Your primary goal as you come out of whatever intensive initial therapy you will undergo is managing your pain. It might be pain from the disease, it might be pain from the surgery or the treatment. Once the pain takes over, it's hard to get back on top of it. It's really hard to stay there. It's important to treat your pain prospectively. Take the medications you're provided when they're scheduled, even when you don't think you need them. Because the fatigue, the change in ingestion, and just the basic underlying biology of undergoing intensive therapy changes your pain tolerance levels. So don't wait to have pain. Take your medications on the schedule you're provided. Remember, the digestive system is a multi-organed system. It's one of the largest, most complex systems in our bodies. Your stomach, your pancreas, your liver, your gallbladder, and the four entities in your esophageal and your intestines, basically, with your colon. So everything's going to slow down. You're going to retain air and feel bloated. You're going to feel gross. You're right on track, and you're absolutely where you need to be, where you should be, right? Nothing surprising about it. So I'm going to sound like everybody's great-grandmother. Eat slowly and chew thoroughly. But it really helps. It makes a difference in what is demanded of your system further down. This is not the time for your fiber. For those of you who are high fiber intake folks, because we know it's so good for us in so many other ways, set it aside. Wait for your system to recover. And this is when I know we must refrain from alcohol entirely. It's always good to reduce and not exacerbate your alcohol consumption when undergoing cancer treatment, but this is a time when we'll ask you to abstain. So the most important feature, what did I say at the very beginning, is your care team. Have emotional support and use it. At a large dedicated cancer center like ours, we actually have an embedded psychosocial support person in our integrated practice unit. This person's job is to meet you where you're at, what's going well, how is your caregiving team in your home life working, what additional support do you need, is there therapy we can offer, are there support groups we can offer, and there's integrative therapy that we can offer as well, massage, acupuncture, and other features. Because this is such a profound diagnosis for many people, we do suggest you reach out to establish these relationships even before you need them. So we're just going to briefly touch on what it's like to recover following pancreatic surgery. I find that we talk a lot about diagnosis and treatment, and we neglect the part where you've now had pancreatic surgery and you have to figure out how to get through it. It's life-changing. So really the first week is to get out of bed and go for walks. They can be short, they can be at a frequency that works for you, but you need to be up and out of bed partially to keep your lungs functioning so we don't have bedridden type pneumonia, just like the olden days, but it also helps your digestive system and your peristalsis start to recover. Before we discharge you from the hospital, we're going to make sure your pain's under control, that you can keep something down like small meals. We don't want to have to rescue you with IV fluids in the community, and that your drains are draining and there's no signs of infections. That's what you can expect. Week 2 then, incremental improvement. By then, you're generally home, you're eating 5 to 6 small meals a day with a big dose of protein in every meal. You're walking every day for 10 to 15 minutes, 2 or 3 times a day. Once again, the goal is to keep you moving so that everything inside keeps moving, but you are going to be tired. Raise your hand if you've had pancreatic surgery. On a scale of 1 to 10, how tired were you in like week 1, week 2? It should be 10. Yeah, it's 10. So this isn't your standard garden variety. I stayed up late last night, I ran a marathon. This is fatigue like you've never experienced before, because the inside of your body is completely dedicated to healing. Your mind is going to feel sluggish. You're not going to feel like eating, even if you can. The fatigue is profound, and honestly, there isn't much we can do for it except ask your care team, that'd be your caregivers, to provide you with the love and support and encouragement to get out of bed, keep moving, keep drinking, keep eating, right? This is the just get through it to get to the other side part of recovery. Week 3, this is when people start to feel better. For those of you who've undergone surgery, was week 3 about when you started to feel better? Ish? Nah, maybe not. Okay. Well, demographically in large populations, this generally is when people tell us they're starting to feel human again. The appetite's slowly improving. Walking duration can be back up to something maybe akin to what it was before surgery. And you can do some things. You can't bring in the groceries. You can't do the laundry, but you might be able to put your dish in the dishwasher. In that case, makes your wife very happy. Adjustments, you're going to need to fine-tune your enzymes and add calorie-dense foods, because we would expect at this point that you might be losing some weight depending on your ability to eat. Week 4 then, we're starting to recover, your energy is improving, you're resuming your normal routines, and if you're off your narcotics, you might even drive. That's up to you, but still small, frequent meals, very protein-dense. Okay, so once again, what do we mostly underestimate? We underestimate the fatigue. It's not just days. It's not just weeks. It can last for months. Nutrition is often harder than pain management. I put that in there reluctantly because I think they're even. I think in the beginning, pain management is harder than nutrition, and then nutrition becomes harder than pain management. Remember, it's good days and bad days. Sometimes it's good moments and bad moments. So if you're having a hard time of it, if your family is getting discouraged with you, you're completely normal and you're absolutely at where you should be. This is when you need to reach out to your professional care team, nutritionist, physical therapist, psychosocial support person to help you get back on track. So the bottom line, it's not linear. Setbacks are common, but structured care definitely improves outcomes. So thank you. It's been a pleasure to be with you today. And I know I'm standing between you and lunch, but time for questions.
I have a question. I have a pretty good support team with me, but I'm single, I have no kids, and I'm at home 99% of the time by myself. Do you have any advice for those of us who are single and need help about how to deal with this?
Absolutely. Plan not to be alone for the first few weeks following intervention or treatment. Are you in a position to do so?
Maybe.
Maybe. Okay. Well, then make it focused and concentrated help. Meals that you don't have to prepare yourself or secure groceries for. Plan your physical activity when someone can be with you, whether I think you shouldn't take a shower alone, for instance, until you're feeling strong and safe. Obviously, no driving or anything that requires, shall we say, sentience that pain medication usually interferes with. So I'd suggest you be very strategic about when you ask for someone to be there and the reasons for them to be there. Frozen meals are your friend.
They have been, yes, and my dog too, so.
Well, the dog. You should have said you have a dog, but in case you're never alone.
Rules change, I
It
understand.
sounds like you get it.
Thank you.
Thank you.
I'm single too, but that's another story. I didn't know we were doing dating here. Okay. One of the reasons why I'm very happy that I'm at UCLA, and one of the reasons why I came here, is because a couple of years ago during one of the symposiums, they talked about an integrated care involving, physical therapy, nutrition, all these things. And it has been very, very helpful getting a big picture in my care. But there have been a couple people that I've worked with, like physical therapists and things like that, that aren't quite familiar with some of the details of dealing with being on chemotherapy or having a 5FU pump hooked up to you and asking you to jump up and down or something like that. So as much as I really do appreciate everything that's going on at UCLA, I sometimes wish there was an in-service or a video or a training, just some way just to inform them, hey, these are things that possibly, if you get cancer patients, which we're telling everybody that we're sensitive to, just to educate them and just inform them about different things that might be going on, because there's been a lot of learning process that's been going on about how to deal with my neuropathy and things like that. And there's so many resources we have here. I don't know if we have to reinvent the wheel for them. The other thing I wanted to say is I do appreciate everything that you've said in this. I wish that I had this video of this presentation at the very beginning of my pancreatic journey. It gives you a structure. It gives you an idea of how to set up your care system and things to expect. So I really would appreciate seeing this video for very early on in my diagnosis, and I hopefully will be able to direct people to this. One thing that I did want to say is something that's been coming up a lot is a lot of our oncologists are saying, oh, I'm going to take you off this chemotherapy because of your quality of life. And usually that refers to, many of the things you're talking about here, the way that I'm digesting, my neuropathy or whatever. And I'm trying to find some way, how are they coming to that determination about my quality of life? How should I be coming to that determination of what my quality of life is? Is there when I speak with my nurse practitioner, there's a little form and says, how's your pain level? How depressed do you feel? I just wish we had some structure so we could kind of understand things that we should be considering when we're talking about our quality of life. That's all.
You just accessed and explained a menu of some incredibly important principles. So I'd like to thank you for that input and feedback. I think specifically to start with physical therapy, we're actually in the process, Tim and I, in working with our rehabilitation program to customize, synthesize, and specialize our physical therapy opportunities. We actually do have clinics that specialize in working with cancer patients. We have the pelvic floor stuff. We have the peripheral neuropathy program. So Google peripheral neuropathy at UCLA Health and see what you get. We actually have entire clinics devoted to both interventions and managing life with peripheral neuropathy. But you hit the nail on the head, which is how do we make sure everyone knows at the outset what to expect and what services and how we're organized in order to best meet those needs. So I think your points are exceptionally well taken, and Tim and I are in a position to do something with them, so thank you. Yes.
Oh, I just wanted to share for those of you who were patients many years ago, and I'm Shelby, I'm the oncology dietitian in the integrative practice unit under Dr. Tim Donahue's leadership. We've made a lot of really, really tremendous changes, so I know a lot of what was just mentioned has now been incorporated in at the first clinic visit, which I'll share in my next lecture. So hang tight a little bit, but I do want to pass it off to our patient navigator just so she can kind of share at that first clinic visit what we are offering to incorporate a lot of the feedback that was just shared.
Yes, hi everybody. My name is Jeanette Villa. I'm the patient navigator for the Hirshberg Center. I'm basically the first person you meet when you call for the consultation. I'm the person you meet in clinic, and then also even after your treatment. I'm sort of your personal assistant from the moment that you call us. But yeah, during clinic, I give you guys, new patients, this folder that includes a bunch of amazing resources that we have for you guys, not only for you, but also for your family members and caregivers. So I'm happy to meet with any of you after the, oh my God, I'm so nervous. I'm happy to meet with any of you just to let you know a little bit more about resources. We do have psychosocial services. We have, obviously, Shelby, our dietitian, and then a bunch of resources that I can also guide you with the tables that we have outside with a bunch of flyers that we have. So if you have any questions, please feel free to come up to me today. I'm available for all you guys. Thank you.
Yay. Thank you both. Yes.
Okay, so I got into my 80s and I was in great shape, so it was quite a shock to get this. But one of the things it was recommended to improve my diet, my appetite was cannabis. I never used it, never thought, I mean, I wasn't drinking alcohol and drugs or anything my whole life, staying in great shape. But what could you comment, because it did help my appetite and it helped me sleep. I'm still a little scared to use it. Might use it maybe once a week. Could you comment, please?
No. Yes. I'm going to look for Tim's guidance here. So the good news is we have an entire program at UCLA dedicated to the use of cannabinoids in cancer treatment. That is about what I can say. Many patients find benefit. They do. So I would encourage you to work with your oncologist to make sure you're reporting what you're using. Of course, someone, where? Tim's pointing. Who are you pointing at, Tim?
You need some help here. I got it.
Thank you.
Amy Reese from the Hirshberg Foundation, who many of you know, fields questions about this all the time, and I think is the most knowledgeable about the resources that we have for advice on cannabis.
I think it's a powerful intervention for many patients such as yourself. You totally don't look 80, so well done to you. Talk to Amy about specific available services for cannabinoids, and thank you for your question.
Hi, I'm a 15-month survivor. I had a successful Whipple surgery in July of last summer. I want to thank everyone from the Hirshberg Foundation that your videos over the past conferences were incredibly helpful in preparing both emotionally and intellectually getting ready for the Whipple. So thank you to all of you. My question for you is, I felt like I was very prepared going into the Whipple. However, I ended up going on to TPN for more than 4 weeks, and I was very unprepared for that. So I was wondering, mostly for future people watching these videos, if you can talk about that a little bit, what the percentages of people who are on TPN, PPN, explaining what that is, and also some of the challenges. I'm more than welcome to share my own challenges, but if you could comment on those topics.
You bet. I'll speak to it broadly, and then Shelby, are you still here, or Tim? So total parenteral nutrition is a fluid delivered through a vein, which venous access can be its own special challenge, delivered by a pharmacy, often in the home setting, sometimes in the subacute skilled nursing facility setting. Total parenteral nutrition means it's food delivered through your IV. And it's generally for people who have stopped eating, are losing weight, and are showing laboratory signs that their body is in distress. For instance, your kidneys are unhappy, and you don't have evidence of electrolytes circulating. So it's the big guns when we're worried that your digestive system is so compromised that we can't wait for you to start ingesting food the old-fashioned way or through a tube inserted into your duodenum called a PEG tube. So TPN comes with a host of side effects. It can cause disorientation, it can cause fatigue, and it can contribute to a sense of lethargy and non-well-being. It's a little funky that way, and that it makes you feel worse, not necessarily better in many cases. Was that your experience?
I did not have too much fatigue or nausea, but I'm on for 16 hours a day.
Yeah.
And for 4 weeks, so it is definitely a imposition on
dialysis
lifestyle.
Or some other disruptive intervention. You're tied to your IV. I see an IV in the room. It's it's a significant intervention at a time in your recovery that's key. So we want to ensure your body has the necessary nutrients to recover, but it's difficult to manage, especially outside the hospital. Shelby, do you want to add anything? There's Shelby.
Yeah, so I think nutrition support, whether it's through a tube or IV, can absolutely be life-saving. There's a time and place for it, so I think it goes back to evaluating if and when that's needed and how we kind of personalize it so it makes sense for your own experience. We've come a long way to learn how to best manage nutrition support in the home setting. So if that's something that you want to be evaluated for or you're not sure of, you can always check in with your medical team and your dietitian to kind of assess for that too, of course.
I'll just throw one note out for future audience members who are watching. I was the unfortunate patient who got a C. diff infection post-Whipple, and so I'm sure that was a major contributor, but I just wanted to throw that out. And I don't know if you want to comment on a C. diff infection.
Clostridium difficile is a bacteria that it lives in all of our gastrointestinal systems, but when it gets into your bloodstream, which sometimes it does after surgery, it can cause widespread infection. It's really hard to treat because over time it's become much less responsive to antibiotics. So I suspect you're correct. There's a connection between the TPN use and C. diff that impaired your ability to heal. So let's hope all of you undergoing a surgical intervention do not experience either a hospital-acquired infection or a systems-related infection because, of course, we opened your gut to do the surgery. It can be very impactful, and you look great considering what you've been through, and you're still very early, so well done.
And again, my last comment would be for the C. diff infection is for future patients. If you are not feeling well, you are not eating, and you just have a general malaise, do not delay. You must get back to your medical team. I went from not feeling great to the ER within 24 hours, and it was very important. If I had delayed another 48 hours, it could be a very different outcome.
That is correct. Well said. Thank you for that inspiration.
I just had a question. I really appreciate this holistic view of this process. And from a peripheral neuropathy perspective, you mentioned PT and that, how does it fit within the larger, I guess, range of how to help manage between different team members and kind of nutrition or other things?
I think peripheral neuropathy is its own set of diagnoses, constellations. Definitely neurology is generally involved. Our peripheral neuropathy programs here at UCLA are run with and for neurologists working with physical therapists and different neurological stimulation pathways to both assess peripheral neuropathy as well as treat it. So I believe it is a holistic intervention, but it's also just like we treat an infection, just like we treat an absence of ability to eat. You need to be evaluated specifically for that side effect and a treatment algorithm recommended. So we do have specific peripheral neuropathy programs that we can provide the links to for you.
Thank you.
You bet.
I just want to apologize, Tim. I didn't hear your question. I just stood awkwardly because I was pointed to. But Jack, we have a great talk from last year's symposium by Dr. Ziva Cooper, who's the director of the UCLA Cannabis Initiative. And I ask all of you to go on our website, pancreatic.org, and watch that great presentation. I think you'll get a lot of answers.
Thank you, Amy. All done? Thank you very much.